diagnosed as right-sided breast cancer at the age of 36 years on 2016. She had no known comorbidity, nor any family history of breast cancer or any other malignancies. She was premenopausal at the time of her diagnosis. She underwent surgery on April 2000 lumpectomy and breast conservation surgery with latissimus dorsiflex and left breast lumpectomy for fibroadenoma. Histopathology of her right breast showed infiltrating ductal carcinoma grade 3 along with presence of extensive intraductal component, perineural invasion and lymphovascular extension. Immunohistochemistry of her right breast shows ER and PR was strongly positive and HER2/neu was negative. Pathological staging of her right breast was PT2N1MX. She underwent adjuvant treatment for her right breast. She received 4 cycles of epinubicin and cyclophosphamide, followed by 4 cycles of paclitaxel, along with locoregional EBRD. Then she was on treatment with tamoxifen and goserelin 10.8 milligram every 3 monthly since November 2016. She was reasonably all right, and her disease-free interval was about 3.5 years. Patient was on regular follow-up, but had to be admitted due to cough, dyspnea, and right-sided pleuritic chest pain on the end of December 2019. Evaluation was done, and on December 2019, her PET scan showed irregular soft tissue lesion in upper outer quadrant of right breast, which suggested disease recurrence, and multiple metabolically active lymphadenopathy was seen, like left supraclavicular, mediastinal, and retrocrural nodes, which were suggestive of metastasis. There was gross left-sided pleural effusion, and there was also suggestive of bone metastasis. Her mammogram showed stable architectural distortion in upper outer quadrant of right breast at the site of prior excision, which was stable since April 2019. This is the picture of her PET scan done on December 2019. As she was diagnosed with metastatic disease, further evaluation was done. Pleural fluid cytology showed no unequivocal malignant cells. Intercostal drainage was drain tube was inserted, and pleural fluid was aspirated for study. And pleural fluid cell block showed scanty metastatic adenocarcinoma. Immunohistochemistry of her pleural fluid showed GATA3 was positive, TTF1 was negative, ER/PR and HER2/neu all were negative. So she was started second-line chemotherapy with eribulin and received cycle 1, day 1 and day 8 in view of her newly diagnosed triple-negative breast cancer. She had repeat biopsy from left supraclavicular lymph node on February 2020 in view of her previous strong baseline, strong hormone receptor positive metastatic breast cancer. Immunohistochemistry of left supraclavicular lymph node on February 2020 showed ER positive, PR positive, and HER2/neu was negative. That is, it was similar with her initial diagnosis. Eribulin was postponed and she was started with hormone therapy. Ribociclib was started from end of February 2020, and she was added with tablet letrozole 2.5 milligram along with injection goserelin 3.6 milligram from 14th March up to early June. Patient needed readmission due to development of shortness of breath and chest pain again on September 2020. For her evaluation, CT scan of chest was done, which showed pneumonic consolidation of left lung and left-sided moderate along with right-sided small pleural effusion. There was also left axillary lymphadenopathy. On 30th September 2020, about 400 ml of hemorrhagic pleural fluid was aspirated. Left axillary lymph node rebiopsy was done on September 2020, which showed ER positive, PR positive, and HER2/neu negative. That was compatible with her primary diagnosis. This is the picture of the CT scan of chest done on September 2020. Due to visceral crisis and non-responsiveness to hormone therapy, she was planned to start single-agent palliative chemotherapy with gemcitabine day 1 and day 8 in 3 weekly cycles. She was started with single gemcitabine from first week of October 2020, and cycle 3 was completed in middle of November 2020. During this chemotherapy period, chest X-ray showed stable effusion levels, and there were no need for any reaspiration of pleural fluids. But she needs continuous oxygen support at her home, and her performance status is 3/5. Following third line single gemcitabine therapy, again evaluation was done with CT scan of chest and liver, which showed small recurrent growth in right breast, multifocal diffuse malignant mass in left breast and chest wall, with associated extensive malignant left axillary lymphadenopathy, matted metastatic mediastinal lymphadenopathy, and there were evidence of widespread metastasis like bilateral pleural, bilateral pulmonary, hepatic, left adrenal, and bony metastasis. That is, overall assessment showed progressive disease state. This is the picture of her third line of her chemotherapy, post-evaluation chemotherapy, CT scan after third line chemotherapy. So we think the questions which need to be discussed maybe how could we explain the left-sided supraclavicular lymph node metastasis with massive effusion in case of previous right-sided primary lesion in breast? What is the cause of failure of hormone therapy? And what will be the next course of treatment plan in case of recurrent pleural effusion with new liver metastasis in view of the visceral crisis after failure of the single gemcitabine therapy? Thank you for your patient hearing.
First of all, I'd like to go to Professor Don S, sir, for your valuable opinion and also regarding the further management plan.
You know, I think the thing that's complicating your issue or your case here is your pleural fluid results from the very beginning, which showed hormone receptor negativity. You have other results in the left side, all of that's hormone positive. But so either this is reflecting two variant or two divergent histologies where you're dealing with an originally hormone positive breast cancer and a subpopulation has become hormone receptors negative, even as other sites are hormone positive, or this is dual processes. So the question for me is, I'm not sure which one is causing her to go into visceral crisis. Is it the receptor negative disease or is it the hormone positive disease? Either case, I think you are right to go to chemotherapy. You know, we do understand that, you know, overall survival results, if you're assuming hormone positive disease, is the same if you do chemotherapy first or endocrine therapy first. You know, in terms of mechanisms of resistance, you know, there are many. We're looking at the ESR1 mutations, which are about 20% of the time you can see them in metastatic breast cancer as a cause of endocrine therapy resistance, particularly to the SERMs, in which case sometimes we will use fulvestrant and a CDK4/6 inhibitor to try to circumvent endocrine resistance to aromatase inhibitors. You know, at this point, she is progressing fairly significantly in multiple organs. I'm not optimistic you're going to be able to control this, and I quite honestly, I think she should probably terminate treatment and go into hospice.
Thank you, sir. Now I'm requesting Professor Rajesh Balakrishnan, sir, for your valuable opinion.
Thank you, Dr. Arunangshu. I totally concur with Dr. Don. This patient has been heavily pre-treated and now currently she is not in a situation to tolerate further chemotherapy. Maybe it's the best time for her to go for best supportive care. There are a few concerns which I might have here is, how reliable is the pleural fluid cell block to assess ERPR and herpes status. So that one is not valid. I'm not sure how reliable we can believe that. If you see, for most of the places, I think she had in the left supraclavicular node and the axillary node, everything were ERPR positive and HER2 negative. It looks like maybe that sample what we have taken from the pleural fluid was not a representative sample, and hence I'm unsure about the cell block, how it was prepared. So basically then that's one thing. The second thing is there are some places where we can definitely find out that the primary and the metastatic side there can be some discordance of the hormone receptors. So that could be basically like if it is a triple negative, that is the most stable phenotype where you can see like even in the primary and the secondary there is not much of a discordance. But ER positive tumors, they are the most near about 30% of them can have some change in the hormone receptor status at the metastatic time. So that is being proven in multiple literature that ERPR status can change while during at the metastatic side. But for this patient, fortunately, it has been ERPR positive in multiple places in the supraclavicular node and in the axilla, which I think hormone receptors would be the best way to go forward. Because the performance status is not that great, I would suggest like one option of either a surgical oophorectomy or maybe a radiation oophorectomy to keep to block her ovaries totally instead of and plus best supportive care as an option currently.
Thank you, Rajesh sir, for your comment. Now I'm moving on to Professor Ahmed side, sir.
So I'd like to thank you for your, that is a very complicated case, you see. Everybody, everything has been tried, but nothing is fruitful. There are cases, there happens to be cases which do not respond to any sort of treatment. Even if they do it temporarily and the disease progresses. So this case is like that. So I totally agree with our colleagues who told that now actually not much you can do for her. Only best supportive treatment and palliative care. That's from my opinion. And from the very beginning, we have seen that the first surgery and the biopsy reports and the immunohistochemical reports and the other reports, everything has shown that that was a very aggressive type of variety. So naturally, it did not respond too much to the treatment offered.
This is really a complicated case where ERPR status have changed a couple of times. We have Khotija Nahar, Madam, pathologist with us. Madam, do you have any comment regarding this case? Khotija Nahar, Madam.
Oh,
Madam
yes.
is joining from UK.
Yeah, hello.
Welcome.
Yeah, thank you very much for asking me to say something. This is a complicated case, and it's a high-grade tumor. So what I think is that when there was a question that why there is involvement of left-sided supraclavicular lymph node in the very beginning and left-sided pleural effusion. So I think that there are two sets of lymphatic supply in the breast. One is the superficial part which goes through the axilla, and the other one is the deeper part. So deeper part, maybe if there is involvement of level 2 lymph node in the just behind the pectoralis minor, that level 2 lymph node involvement might have subsequently involved the intercostal lymph nodes and subsequently to the mediastinal group of lymph nodes and the supraclavicular group of lymph nodes. And regarding the pleural fluid cell block, I would also agree that there was very scant amount of adenocarcinoma cells found. So it is very hard to say, hard to comment on the immunohistochemistry report in this in that perspective. So rather, immunohistochemistry was done on the supraclavicular lymph node and subsequently in the left supraclavicular lymph node, I think twice, and the initial hormone status was all the same. So the case might be considered as hormone positive case. That's what I think. Yeah.
Thank you, Madam.
And I think this condition, the spread and early spread and all these things, might be because of the size of the initial tumor and also the grade. It was a high grade and also the involvement of level 2 lymph node in the axilla. So,
thank you, madam. Thank you very much. Salim Reza, sir.
Thank you.
Thanks, Dr. Arunangshu. Actually, this is a very complicated case. We are also facing these problems in our regular practice. In these cases, there are 4 times the immunohistochemistry was done, but 3 times ERPR positive, HER2 negative. 1 time it was triple negative. That is in the pleural fluid cell block study. So I should say this is basically a case of hormone receptor positive breast cancers. But she received all sorts of treatment. In this case, as the disease is spreading the whole of the body, I should say bones, adrenal glands, liver, lungs, body functions. So I think she should be kept in a palliative management. And one may choose the hormone therapy, but I'm in favor of only palliative therapy. Thank you, Dr. Arunangshu.
Thank you. Thank you, Salim sir, for adding something. Dizon sir wanted to say something. You raised hand.
Yeah. I mean, I think what's so remarkable about your case is that her disease-free interval was quite long, right? It's 3.5 years from the time she was originally treated, and she's now not responding to treatment for hormone-positive breast cancer. If you assume, as Professor Begum has stated, that you can't really rely on the cell block. There was one thing on the PET scan that did catch my eye, and it was that the fundus of the uterus lit up as well. And the question I would have is, was that pursued? And were you also dealing with a uterine cancer as well? Because those can be hormone positive as well. Endometrioid cancers of the uterus can be that. And I'm wondering if there's a possibility where there was a second malignancy in this very young woman that we didn't realize and we're calling metastatic breast cancer. It's very unusual for someone to have this kind of aggressive disease, right? With hormone positive disease and a 3.5-year interval. Typically when I see young women do poorly with breast cancer, they don't have that interval. They tend to recur within a year. But in terms of other options that we would be using in metastatic breast cancer, we would be looking at, testing her for BRCA. We would be looking at sending her tumor for genomics to see if she had a PI3K mutation that would allow us to use alpelisib, which is a new drug here in the United States. You could even, quite frankly, had her performance status been better, which I think I agree with my colleagues that it is not, even repeat use of a CDK4/6 inhibitor, ribociclib alone, can get it at 1 in 5 can respond to that as well. So that was the only thing that I also had to suggest is, were you missing a second malignancy that could also be hormone positive, but essentially was not being treated? You're grasping with straws now, given that she has cancer pretty much everywhere.
Thank you, sir. Qamruzzaman sir, your final comments regarding this case.
This is a very complicated case is what we have treated here, especially these patients have got half of the treatment he got in neighboring countries, and the rest we treated in our centers. And we have faced problems when the patients are coming with the recurrence, especially after treating with the hormonal manipulation 3.5 years. Initially, it was a hormone sensitive tumors. You can see that ERPR was maximum 8, score was 8 and 7. So and it responded for 3.5 years. After that, there is we know the breast cancer is heterogeneous. Some portion may be receptor positive, some portion may not be receptor positive cases. So that may be one issues. And as the patient got a third-line chemotherapy, patient became exhausted, and patient has a lot of organ involvements in that cases. One issue that focus on Dizon, there may be a second malignancy, what that comes from the uterine ones. That issues that actually we didn't thought about even is, but we should think about is when the patient's coming with a lot of treatments, failing the treatments with a multimodal approaches like hormonal chemotherapies. So that is my comments is that patient has exhausted with chemo and hormonal manipulations. We can put the patients in just a supportive care. And another thing, since the patient was initially hormone receptor positive, can we think about if the patient wants, we can for the CDK4 and also fulvestrant, we didn't use that one. So we can think about if the patient wants. Otherwise, patient should be kept in, I think, supportive treatments because patient is exhausted.